So, thank you very much, Professor Adams, for participating with your interview in the Microbiome Immune System and Inflammation Congress, organized by Enevia Health. We will upload this interview together with the recordings of all the presentations from the Congress. My name is Natalia Marmol, co-founder of Enevia Health, and I will be asking you the questions that the families have asked us. Before we start with the interview, I would like to thank all the sponsors of this nonprofit event. Without them, it would have been impossible to do. American Rare Disease Group, Teletest Lab Analysis, Algemica, AVD Lab, FDB Laboratorios, Phytoinnova, XLBit, K Biological, Techial, Ricobus, and NOAA. Thank you very much for believing in this project. And a big thank you to all of the volunteers that have helped immensely to organize this event together with Enevia Health. I would like to start this interview by asking you to please introduce yourself.
Yeah, I'm Professor James Adams. I direct the Autism Research Program at Arizona State University.
Thank you, Professor. So what influenced you to pursue looking into FMT for the treatment of autism?
Well, we've known for many years that children and adults with autism often have chronic gut problems, usually constipation or diarrhea, or often alternating between the two, along with a lot of pain and discomfort. There was a study in 2000 by Sandler and co-workers in which they found that a treatment with Vancomycin, a special antibiotic that's not absorbed into the body but only acts in the gut, they found that that treatment of Vancomycin was very beneficial. They treated people with autism for 8 weeks with it, an unusually long course, and they found a slow, steady improvement in GI symptoms, and surprisingly, a slow, steady improvement in autism symptoms. Unfortunately, when they stopped the treatment, the GI benefits and the autism benefits were lost within a few weeks. And so our thinking is that the antibiotic was effective in killing off the harmful bacteria, but it did not prevent their regrowth after the antibiotic was stopped. And so we thought that what we needed to do was try to reseed the gut with beneficial bacteria in order to prevent the regrowth.
Perfect. So what is the difference between fecal microbiome transplant and microbiome transfer therapy?
They're very similar. The difference is that fecal transplant is the term that was originally used, and originally people were just using raw feces, which contain a lot of live bacteria, but also a lot of waste product. They were using it initially for treating people with a very dangerous gut condition called Clostridium difficile, or C. diff. And that condition causes explosive, life-threatening diarrhea. It causes many injuries in the US. 500,000 people a year catch this very severe GI disorder, and 29,000 people die from it. So it's a life-threatening. It was found that just one dose, one time, was enough to cure people within 2 to 3 days. So fecal transplant has traditionally been viewed as being used for one dose, one time, for treating C. diff infections. We worked with the gastroenterologist, Tom Barodi, out of Australia, who's treated over 17,000 people at his clinic with fecal transplant. He found that children with autism were much harder to treat. So he used a much more intensive treatment in which he pre-treated with antibiotics and then treated every day with a highly purified set of gut bacteria. And so we used the same approach, which he found was very beneficial. And that's why we call our treatment microbiota transplant, because we're using highly purified gut bacteria. It's over 99% pure gut bacteria. And we're doing not just one dose, but many doses. And we're also pre-treating with Vancomycin. So it's a combination of a pre-treatment with Vancomycin, a bowel cleanse, and then this high intensity of microbiota for 7 to 8 weeks that we found was beneficial, whereas just one dose, one time isn't. So we wanted to have a different name to differentiate the way in which people do the treatment. One dose, one time versus the full pre-treatment with a bowel cleanse, with antibiotic, with 7 to 8 weeks of treatment.
I see. So could you please tell us about your recent phase 1 research and the results of using Microbiome Transfer Therapy for autism, please?
Yeah. So we conducted a phase 1 study. That means an open label study. Everyone received the real treatment. It was for 18 children with autism, ages 7 to 16 years. We treated them with oral vancomycin for 2 weeks, the antibiotic to kill off bad bacteria, and then a bowel cleanse, like you'd have for a colonoscopy, just to remove as much stool and gut bacteria as possible to make the gut as clean as possible. And then we gave them the Microbiota Transplant for 7 to 8 weeks, a high dose and then a maintenance dose. And what we found is initially great reduction in GI symptoms, about an 80% reduction in GI symptoms, and about a 25% reduction in autism symptoms. Now there's some placebo effect because it's an open label study, but it seemed we were seeing some good benefits. And then when we stopped treatment, we waited 8 weeks. And unlike in the Sandler study where they used only vancomycin and the benefits were lost within a few weeks, at 8 weeks, all of our benefits were still there. There was no loss of benefit. And so we published our paper, and we also found that at the start of the study, children with autism were missing about 25% of their normal gut bacteria. But after treatment, it had normalized. So that was very encouraging. But then a year later, several families came up to me and said, Professor Adams, my son's doing better than ever. So I said, this is very interesting. So we did something very unusual in science, which is a follow-up study. Mm-hmm. So we followed up with all of the families 2 years after treatment had stopped. And what we found is that most of the GI benefits remained. There's one child who had taken an oral antibiotic and had lost some benefit, but most of the GI benefits remained. But family after family reported their child just slowly, steadily continued to improve. It just seemed like their ability to learn was better, and they were continuing to make good progress in their language, in their behavior, in their social interaction. And our professional evaluator reported about a 47% reduction in autism symptoms at 2 years. So very encouraging. Another way to say it is that at the start of the study, 80% of our children had severe autism. At the end of the study, only 20% had severe autism, 40% mild to moderate, and 40% below the cutoff for autism. They still had some symptoms, but they didn't quite make the cutoff for even mild autism at that point. So overall, very, very encouraging.
It is. So could you please explain what does it mean to be on the FDA fast track status?
So based on our research, the FDA awarded us fast track status, which means that they recognize that this is a promising, not proven, but promising treatment for an unmet need. Right now, there is no FDA-approved medication for treating the core symptoms of autism or for treating the GI problems in autism. So this treatment seems to be very effective in treating GI problems, but also addresses all 3 core autism symptoms. It seems to improve language, social interaction, and behaviors. So we need randomized double-blind studies to prove that, but it means that FDA is very supportive of our work and is helping us move forward quickly.
If the results from phase 2 are successful, how much longer do you anticipate it will be to get FDA approval?
Well, it will take us about 2 years to conduct our phase 2 studies. So right now we're doing a phase 2 study for children and another phase 2 study for adults. And because we're doing both several months of treatment and then also doing a long-term follow-up for 18 months, it will take a couple years to get those results and to be able to submit them to the FDA. After phase 2 studies are done, then the FDA generally requests a phase 3 trial as well. It's a much larger study, 10 times as large, of order 10 times as large, 10 times the cost, and so that would also take several years. So it's still a ways down the road to get FDA approval. We're doing the best we can, but the FDA is cautious and it takes time.
Yeah. In another interview, I heard you saying you were in the process of researching the possibility of a compassionate care. What's the latest update on that? For those that don't know what compassionate care is, would you mind explaining a little bit what it is?
Yeah. So compassionate care means that when someone has a life-threatening or serious disorder, the FDA can consider allowing the distribution of a medication on a limited basis prior to the full release. And so if our phase 2 studies go well, then we can consider asking the FDA for compassionate care, meaning that a limited number of people outside of our research studies would be able to access the drug. They'd have to pay for it out of their pocket. They'd have to report any adverse events to us. We may ask them to collect some additional data for us as well. But that would probably be a couple of years down the road.
Would you mind, before we get into the questions that the family have asked us, would you mind explaining briefly what your treatment is? So what did you do in your study?
Yeah. So as I mentioned before, we used vancomycin, which is a special antibiotic designed to kill off certain harmful bacteria in the gut. The problem is it does probably kill off some beneficial bacteria as well. So it's not perfect, but it's the best antibiotic we know of at the moment to use, and it's worked well. And then we used a bowel cleanse. We used MoviPrep, which is basically causes you to just empty your bowels, basically causes extreme diarrhea just for one day to flush out any food, flush out any stool that's left. So the gut is as clean as possible, has as few bacteria as possible in it. And then we do a high-dose microbiota transplant and then low-maintenance dose for 7 to 8 weeks.
Okay, perfect. So we will start by asking you one of the most popular questions. Is it necessary a pretreatment with vancomycin before a microbiome transfer?
It's a great question, and the answer is we don't know, because the one study we did, we used the vancomycin, and we did see that study was very successful. Is it necessary? We don't know. In our new studies for children and adults, half of the children and adults will receive the vancomycin, half won't. They'll get just the microbiota and the bowel cleanse, and we'll see if one group does better than the other. So we'll find out, and we're researching that.
Are there any side effects to the use of vancomycin?
A very interesting thing is that in the Sandler study, when they used vancomycin for 8 weeks, they did see some adverse effects in about half the children, had increased irritability for usually just a day or two, so for 1 to 4 days, and usually right at the start of the vancomycin treatment. And so our interpretation is that as the vancomycin kills off the harmful bacteria, those bacteria release all of their toxins all at once. So the symptoms they were causing worsen. And then as those bacteria are killed off, then the symptoms they were causing should decrease. And so that was what they found in the Sandler study. In our study, we found something very similar. We found that about 2/3 of the children had temporary adverse reaction, either increased irritability or increased hyperactivity, and that lasted usually just a few days. In one case, it lasted for several weeks, and then it got better. So we think it's just what we call a die-off reaction, and we think it's just a temporary issue.
Okay. Yep. So lots of people are concerned with the gut permeability and the effect of the microbiome transfer therapy. Could this new set of bacteria and virus go through the intestinal walls and leak to the bloodstream, causing an infection? Should people with high markers of permeability treat this issue first? Or do you think that with the MTT will resolve itself?
Well, it's a good question. And certainly there are a number of studies which show that children with autism tend to have increased gut permeability. But generally that's for small molecules. Bacteria are much larger. And so it seems that there's no reports that I'm aware of gut bacteria, harmful gut bacteria leaking from the gut into the blood of children with autism. And so we're simply transplanting gut bacteria from very healthy donors. And in our study, we did not see any evidence of that. We think our treatment, if anything, would likely tend to reduce gut permeability problems, but we didn't measure that, so we can't say for sure. So all I can say is that the microbiota seem to be very well tolerated. Unlike with the vancomycin, where there were some temporary die-off reactions, with the microbiota, we had 0 reports of adverse effects, that it was just very well tolerated. So we're basically just restoring a normal, healthy gut bacteria in these individuals.
So then you're saying that people shouldn't have it in consideration, so people that has permeability could go ahead and do the treatment?
Yes, that should be fine. I mean, unless they had a severe rupture of their intestines, which would be life-threatening immediately. Yeah. And so it should be very safe. A good analogy would be taking probiotics. Essentially what we're doing is giving a super probiotic, not of 1 to 10 species that are grown in milk that are typical probiotics. We're giving 1,000 or so species from very healthy donors. So a good way to think of it as a super probiotic.
When would it not be advisable to do the microbiome transfer therapy?
In general, microbiota transplant has been used for decades and generally has been extremely safe. The only there have been only 2 harmful reports, 2 reports of serious harm that just were announced about half a year ago. And what had happened was that 2 people with compromised immune systems, weakened immune systems, received a transplant from the same donor, and that donor had multiple drug-resistant bacteria. Didn't affect the donor, so the donor didn't have any symptoms, but when it went into these 2 people who had compromised immune systems, they both became very ill, and one of them actually died from the infection. They weren't able to be treated with antibiotics because the bacteria were resistant to them. The person who died had just had a bone marrow transplant, so their immune system was purposely almost completely suppressed by the medications. And so that's the one case where you would not want to give microbiota transplant to people with a severely compromised immune system, such as someone with AIDS or someone on immune system suppressant drugs for a transplant. But also, the FDA asked all researchers to now require that they check for drug-resistant bacteria in the donors. Mm-hmm. Our research collaborators already did that, so for us it was no problem, but we're glad that other people are now doing that. So that hasn't been a problem with us, and we hope it never will be.
Okay. Have you got to a consent on the duration of the treatment? Do you think it should vary depending on the person's microbiome before the MTT?
Probably it would, but we don't know enough yet. What I'd say is that in our treatment, our first phase 1 study, we went 7 to 8 weeks of treatment, and it seemed to be very well tolerated. There was no problem, no adverse effects from the microbiota. And during the treatment, it just seemed every week that children's GI symptoms were improving up to about 5 weeks. So it seemed about 5 to 6 weeks of therapy, including the 2 weeks of Vanco, were sufficient to treat the GI symptoms. But it took about the full 10 weeks, so 2 weeks of Vanco, 8 weeks of FMT to improve autism symptoms. And it could be if we treated longer, we'd see even more benefit. And so in our first study, 90% of our children had a great improvement in GI symptoms. Only 2 didn't have much improvement. My guess is that if we treated them longer, we may have had even more, a higher rate of improvement, possibly. So we're now, in our present studies, going with approximately a 12-week treatment study. And we'll see if longer is better. A good thing to realize is that our first study, we were guessing about dosing, guessing about duration, kind of like with aspirin. When aspirin was first developed, do you take a tenth of an aspirin? Do you take one aspirin? Do you take 10 aspirin? How much do you need? And so all I can say is we have a treatment that seems to be very well tolerated, and the dosing and duration we used worked well, but because it was so safe, we're now going to higher dosages, higher duration.
In your opinion, what makes a good donor? Some people hypothesize with the idea of a healthy sibling, similar age, ideally similar sex, to be the best donor. What are your thoughts on that?
You inherit most of your microbiome from your mother, and so we don't think using siblings is a good idea because they've received the same donor, that they've received their gut bacteria from the same mother. And our studies suggested that mothers of kids with autism had slightly lower fiber intake and probably contributed to a worse gut bacteria. So we definitely don't recommend donors or parents. The American Gastroenterological Association has certain criteria for donors. They recommend first following the rules for blood donors, so checking for no infectious disease, checking for no exposure to people with infectious disease, checking that the donors are in very good gut health, no history of gut cancer in their family, and then also that they're on healthy diets, that they're not unusually thin or unusually overweight, but just a good optimal body weight. So those are some of the major criteria they look for, as well as testing the bacteria for any abnormal bacteria in there.
There is a concern about the pills being able to cause SIBO if they open in the small intestine. What do you think about it? Do you have any report cases? Why not using the rectal administration to reduce the risk of SIBO?
Okay, so in our first study, the first dose was given in some cases rectally, in some cases orally, and then the maintenance dose was always given orally. In our first study, we used a liquid formulation along with a stomach acid suppressant, so that way the bacteria could survive the stomach, because normally your stomach acid would kill off almost all of it. And then it went into the small intestine and then the large intestine. The small intestine is important because the gut bacteria do make some key nutrients, such as vitamins, and those need to be absorbed in the small intestine. So we think it's important that our treatment, our gut bacteria get into the small intestine, as well as especially into the large intestine. So you have gut bacteria in both places, and the gut bacteria are somewhat different. Research still needs to be done on that. But all I can say is that we had no cases of SIBO, and the treatment was very well tolerated in our study.
With patients with minimal improvement, have you found anything in common amongst the microbiome?
We had only 2 patients who had no major change in their GI symptoms, so it's not enough to really say what was happening there. We just need to do a larger study to find out, but right now we can't see any major differences.
We have another family that is asking, have you had any consideration on how heavy metals could affect the outcome of the MTT?
We've done a lot of research on toxic metals. There are over 40 papers, most of which suggest that children with autism do have higher amounts of toxic metals in their body, primarily due to lower glutathione, which is the body's main defense for binding to toxic metals and excreting them. The problem with glutathione is that when it binds to a toxic metal, it excretes it into the gut through the bile. And if you have bad bacteria, then it can just be recycled. So there have been studies showing that for mice on antibiotics, it takes roughly 10 times as long for them to excrete mercury because they keep dumping it into the gut. The gut bacteria remethylate it if you're on antibiotics, and then it just gets reabsorbed. So I think it's the reverse. I think that harmful gut bacteria can cause, for example, the recycling of toxic metals back into the body. But in general, we haven't looked, we've studied both topics, but we haven't studied both together. So I can't really talk for sure about the interaction, except for the methylation of mercury.
What would you do if a patient developed a severe complication to the MTT? Could you wipe out the newly introduced microbiome with antibiotics? What would happen if the cause of the complication wasn't known? What would you do?
Well, the most likely case would be, as I mentioned, the two adverse cases that we know of where someone received a harmful drug-resistant bacteria from a donor. And so what could be done, what was done in those cases was high dose of different antibiotics to try to figure out one that they are not resistant to. So that's what could be done if someone did, in the very unlikely case, have a harmful reaction. But there have been tens of thousands of microbiota transplant, and we only know those two serious adverse cases. So I think the risk is very small, but it's not zero. And that's why we are doing these research studies and trying to carefully monitor for adverse events.
We have here, some parents have reported cases where the kids experience a regression on the autism symptoms together with seizures after FMT treatment. Why do you think this happened? What would you recommend they do? I know this is FMT, not MTT, but since you are an expert, we thought we would ask.
So you're saying, what if someone had a bad reaction after a microbiota transplant, after a fecal transplant?
So they had it. So these parents are saying they had seizures and they had a regression on the symptoms of autism after a treatment with FMT. So they are asking, what would you do if that happened to you?
Well, first of all, we only recommend doing it as part of our research studies because it's an experimental. So that way we'd have data to try to understand. But if it occurred, one could first try to make sure that it really is due to the fecal transplant. And if it seemed, based on the timing, that it was, one could then speak with their personal physician about what would be the next step. It could be the physician would want to recommend certain types of antibiotics to check for what are potentially harmful bacteria like C. diff that might have been passed on from the donor. So that would probably be the first thing to look for, is to check the donor's stool, see what harmful bacteria they might have had, or see what harmful bacteria are in the recipient currently that could be causing symptoms. Certainly, the gut bacteria do make a large number of neurotransmitters, and because about 25% of people with autism have seizures, and about 60% have subclinical seizures, that's something that we do watch for carefully. In our study, no one had a seizure history, and we're being very cautious about admitting people with seizures because it's possible that one could have a seizure after making a major change to your gut bacteria, because it's also going to make a major change to your neurotransmitters.
Thank you. One of the biggest concerns of the families is the uncertainty of what could happen when transferring a microbiome, since it also implies transferring genetic information and the possibility of developing an illness further in life. What are your thoughts on that? Well,
that's something that people do wonder about. With the case of Clostridium difficile, the amazing thing is that when you treat Clostridium difficile with fecal transplant, it's virtually unheard of for you to ever have a recurrence again. Whereas if you treat with antibiotics, about 20% of the time it comes back. So it seems that fecal transplant for people with C. diff infections results in a lifelong change and a greatly reduced chance, near zero chance, of having a C. diff infection recur. In autism, we've done a 2-year study, follow-up study, and found that in general, the children were doing very well, even better with autism symptoms than they were at the start. So I think that we have a lot to learn about gut bacteria, and that's why we're doing the study, to see what are potential long-term changes. We know that with people with ulcerative colitis and Crohn's disease who have a fecal transplant, there's about there's of order 20% chance they might have a temporary flare-up of those conditions, but longer term it seems to help with a wide variety of GI conditions as well. So the bottom line is we don't know about long-term effects for sure. I will say that one of the parents in our study, phase 1 study, I saw a few nights ago, and he said, Professor Adams, my son's doing better than ever. He's in college now, he's doing great. I asked him about his gut problems, and he said, oh, Dad, those were eons ago. I don't have those anymore. So it just seems that for many cases, not all cases, the results seem to be long-lasting, and we don't know of any serious adverse risks. But we can't say there are none. That's why we're doing the research.
Okay. In your experience, which is the autism symptoms that see more improvements with the MTT, and which ones are the ones that see less?
I don't have the full list in front of me, but we do see improvements in all 3 core symptoms of autism, in language, in social interaction, and in repetitive stereotypic behaviors. It certainly seems that the social interaction is more noticeable, especially in the adults as we treat them. And so we also see improvements in common symptoms. So of course the improvements in GI symptoms I mentioned. We've seen reports of improvements in sleep. We've seen reports of improvement in anxiety and in depression. But those aren't that as common. And so again, we've seen some reports of that, but the major reports seem to be in the core symptoms of autism.
Have you seen more better, how do you say, improvements in kids or in adults?
Well, we published the data on our children's study, ages 7 to 16, and there it didn't seem to matter what the age was. In our current study with adults, it seems the adults are taking a little bit longer, a few weeks longer to show benefits. And the benefits, they're seeing some of the same types of benefits. Whether or not there is much, we'll have to wait to find out as we analyze the data.
Perfect. How much do you think it influences the diet in the success of the MTT?
During our study, because we're trying to get FDA approval, we had to require that the families not make any changes in diet, in supplements, in medications, no changes in anything except for the MTT itself. But we do know that after the study, a few families did try to improve their diet as well, but most stayed on the same poor diet. So we analyzed 5 factors that were risk factors for developing these GI symptoms, and our small study suggested 5 risk factors, one of which was lower fiber intake by the mothers, less eating of whole fruit, whole vegetables, and of the children. The children with autism ate slightly less vegetables and fruits than typical children. In our phase 1 study, roughly 2/3 of the children were born by C-section. When you're born by C-section, you inherit less of the bacteria from your mother. They also had a much higher use of oral antibiotics, and they also were breastfed for a much shorter period of time. And breastfeeding is very important to help normalize your initial gut bacteria. So we think those were all factors. So we think especially breastfeeding, a very critical part of diet, your initial diet, the first few months of life. But later on, our impression is that changing diet alone, once these GI symptoms have set in, doesn't seem to, in most cases, make a major effect. It seems that adding in high fiber doesn't help once these problems have occurred. But being on a high fiber diet is important to help prevent these problems because your gut bacteria convert fiber into certain chemicals like butyrate that are the primary food for the cells that line the gut. So if you aren't eating enough fiber, and most Americans are eating half or less the recommended amount of fiber, maybe in Spain you eat healthier, I don't know. But in America, very low fiber consumption, and that is probably the reason, a major reason why so many Americans have chronic gut problems.
Do you think it's possible to emulate the MTT just with probiotics?
No, not with standard probiotics. Standard probiotics are typically 1 to 10 strains of bacteria, and they're generally strains of bacteria that are grown in milk, in a culture in air. So many of your gut bacteria are anaerobic. They're destroyed by air. They grow in your gut where there's very little air, very little oxygen present. So they'd be killed by the presence of oxygen. So a good analogy is if you have a garden and you want to grow a wide crop of tomatoes, cucumbers, corn, and you only plant radishes, you're never going to get those other crops. So if you want to, we find that we're replacing hundreds of new species of gut bacteria, but one child may need this several hundred, another child may need this several hundred. And so with a standard probiotic, you're only giving a few strains, and generally those strains, when you stop taking them, will disappear from your gut within a week or two. So although the principle of probiotics is a very reasonable one, in practice, we're generally giving the wrong probiotics because we aren't giving the ones from a healthy human gut.
You said before one of the persons doing the trial had to take antibiotic. And so what happened to the microbiome of this person?
So right at the end of the study, we had one person who at the end of the study took oral antibiotics. Temporarily, at the 8-week follow-up, their gut symptoms were still had improved. But at the 2-year follow-up, they were one of the people who lost all their benefits of GI symptoms. Some of their autism symptom improvements remained, but they hadn't made as much improvement as others.
So do you think then that the moment that these people that is having improvements will take again antibiotic, they will stop seeing the benefits of the treatment?
There's some risk, and there's, I think, more risk right at the start as the gut bacteria are still establishing themselves. So I'd certainly recommend delaying antibiotics as much as possible unless there's some critical need for them.
Have you ever met an autistic person with a healthy microbiome? Would you say that mostly all autistic persons have a dysbiotic microbiome?
In a paper we published in 2013, it was a small study, about 20 people with autism. Some of them did have severe GI problems, some of them did not have GI problems. We found that all of them, on average, had a much lower diversity of gut bacteria. They were all missing several hundred species. And in particular, they were missing one species of bacteria called Prevotella. Mm-hmm. We're very interested in Prevotella because in people on very healthy diets, so a study done in Africa on people on traditional, very fiber-rich, plant-based diets, half of their gut bacteria was Prevotella, and they had minimal GI problems. In Europe and in the US, less than 1% of your bacteria is Prevotella. So going from 50% to less than 1%, and kids with autism 10 times lower than that. So it appears that our small studies suggest most children with autism are missing Prevotella, as well as many other, hundreds of other species, but it varies from one child to another as to which of the hundreds of species they're missing.
So from 100 species to how many are they having, the people after 2 years now?
We found that at the start of our study, the children with autism had a lower level. At the end of treatment, their level had normalized. 2 years later, they had a higher diversity than typical children. So it seemed that, and in general, higher diversity is associated with a healthier gut. So it seemed that overall, we had a great improvement in diversity.
Okay. I heard you in another interview saying that you use just maximum 2 donors for each treatment of each patient. So would that be that each donor of your, how do you say, the donors that you use have this really high diversity, or they are just average?
Yeah, so we work with a group that selects the donors and processes the material for us, our collaborators at University of Minnesota, and they screen the donor population extremely carefully. 90% of the general population does not pass. Only the 10% healthiest are allowed to be donors. So we have a very rigorous screening process for them.
Do we know, I don't know if that's published, that's part of the missing the word in English, as in you're not allowed to say it, but do we know your donors, the amount of species that they have, the diversity they have? Have they published their
Yes, that was in our paper. We plotted the we had different donors. Some had higher diversity than others.
I see. What do you think about, changing a little bit the subject, about intestinal candida? Do you think it's an important factor to have in consideration when doing MTT?
It's a great question. There are about half a dozen studies showing that about a quarter of people with autism have higher levels of yeast, especially Candida albicans, but other types of Candida too. And I've certainly heard a lot of anecdotal reports that when children are on antifungals, they do better. There's a research survey, so just survey data from the Autism Research Institute. They surveyed 25,000 families, and the 2 top-rated medications for improving autism symptoms, including all psych meds, the 2 medications most highly rated by families were 2 antifungals. And so it's just very intriguing that autism families have reported in this very large survey that antifungals are very helpful in reducing autism-like symptoms. But often it seems, again, anecdotally, that they also need to be on a low sugar diet, or when they stop those antifungals, the bacteria come back, the fungi come back. We did not have the funding in our first study to investigate fungi. That's something we're interested in looking at now. And so we'll be hoping to do that in future studies, but honestly, it's expensive to do. It's more expensive to look at yeast than at bacteria, and it's more complicated. So it's on our to-do list.
Okay. What about parasites? Do you think it's an important thing to treat before MTT?
I think parasites can be certainly a problem. In one study we did in the US, we worked with a group, Doctors Data. We sent 20 stool samples to them. Their lab is very good at checking for parasites, and they all came back negative. So at that point, we stopped testing. Again, it's a question of what is most important. So if someone does have obvious parasites, sure, I think it would be great to treat ahead of time. But in the US, that seems to be relatively rare.
And one family is asking, have you seen better results in younger children? Is there an age in which benefits start decreasing? As I say, in our phase 1 study, we looked at children ages 7 to 16. We didn't see an age effect. It's possible when we go to younger ages, we may see more benefit by treating earlier. That's our hope. And in our new child study, we're going down to age 5. So we'll get a little bit more understanding. Have you seen any difference in progress when it comes to males versus females?
We only had 2 females in our first study, so it's hard for me to say.
Do you think is it worth studying the mother's microbiome, the type of birth, and if they nurse or not? Have you considered it relevant to identify possible subtypes of autism?
That's part of what we look at in the medical history. We think an important part, as I mentioned, is because you inherit your microbiome from your mother. then we think it's very important that a mother's microbiome be as healthy as possible, avoiding C-sections, avoiding antibiotics, and nursing for as long as possible, we think are all important to help establish a healthy gut bacteria.
I see. Well, we have some other questions. Sorry, I'm just reading, but I think we are running out of time. So I don't know if you still have more time for more.
I can take a few more questions if you have them.
Yes. So I have some parents here that were saying if you wouldn't mind to give your opinion on the current F&T treatments that we have available. I don't know if that is something that you would give your opinion, but they ask.
Okay. In general, I don't want to comment because I don't know what protocols other groups are using. I'll just say we have published what our protocol is. It seemed to work very well. And so I recommend families can look at our protocol and can compare that against what protocols other groups are using.
Do you think your study would be, so some people here in Spain, for example, they are wondering if your study could be replicated by universities here, or is that something that you want to conclude in your country and then if it gets successful then replicate elsewhere, or could like some other facilities here, universities, maybe work with you in order to do another study here similar or like touching other different things?
So we're very open to collaborations. If there's the main issue is we would need funding to do a study in Spain, and we would need a local collaborator there who's experienced with doing clinical trials. But if we had funding, if we had a clinical collaborator, we'd be open to discussing that with them.
Well, that sounds promising. So if there is anyone watching and anyone wants to get in contact with Professor Adams, please do so. We'll be happy in Spain to have more research about this subject. So, and another question that we have here, we touched before a little bit the compassionate care, but the company that is producing the material that you use, what would it take for them to be able to sell that to other countries, for example, where the law allow for these treatments to happen?
Currently, I don't believe they'd be allowed to do that because of FDA requirements on production. So I don't believe that they could do that in the US. Now, if they had an arm in another country where it was legal to do it, then they could consider doing it there, I suppose. But that's, I'm not an expert on the law and the issues there, so I'm speculating a little bit.
I see. Well, those are all the questions that we had prepared for you today. I really appreciate your time, and we really thank you for all the amazing studies that you are doing for all the families and for all the autism course. And we hope that the study that you are doing now, it comes out with great conclusions and that you can move forward so that the FDA looks at this and sees this is a great treatment to have. Thank you very much, doctor. We hope to have the opportunity again to talk to you, and we wish you the best.
Thank you very much. And many thanks to all the families who have been in our study and to the many thousands of people who have donated to support our research. So thank you.
Oh, one more thing. Sorry, now that you say that, I forgot. Would you mind letting the families know if they want to contribute to any of the studies that you are currently doing, how can they support you? Yeah,
so we have two GoFundMe pages, one for a child study, one for adult study. And so if people would like to donate to those, we'd be very welcome. It's only because of the donations from families that we've had the funding to go ahead and do our current child study. And we hope to be expanding on that.
Okay, so we will put a little link when we do the editing of the video. So thank you very much, doctor, and hope to talk to you again. Thank you.